for all of us. So why is this so important? And that is because Hong Kong really has an aging population, and so does Australia and many other countries around the world. And the reason we have an aging population is because of sustained low fertility. And if you've been with me before in some of the other webinars that I have done for the Hong Kong and through Asia, I've done some on fertility. So we know that this is a problem, particularly in Hong Kong. You all work long hours and are very career orientated, and the fertility rate is quite low. And in addition to that, there is increasing life expectancy. People are living longer, but this doesn't mean that they are living longer and living a healthy or I guess a functional lifestyle. A functional life. A lot of people sadly are living longer, but they are suffering from chronic disease or, cognitive issues. So as I've just mentioned, as the proportion of Hong Kong people are living longer and getting older, so does the rate of chronic health conditions and age-related cognitive decline, particularly Alzheimer's and dementia. So when we look at the most recent statistics, 2019 is the data we have. It's the same for Australia. It always takes a couple of years for them to publish the data, so we don't know for 2020 or 21. But looking at, just a few years ago, most recently in Hong Kong, if we're looking at this bar chart over here, you can see that less than 20% of the population, close to 20% of the population currently in Hong Kong is age 65 or over. However, in the next 50 years, that is really going to increase significantly and is expected to at least double. If you move over here to this graph where you can see the median age, we're ranging from 50 to 60 here, if you can see my cursor. And then down the bottom on the horizontal axis, again, we're looking at 2019. Over the next 50 years, we can see that the median age is increasing. And this has a lot of impacts on the economy because there are less people working. But as I said, there are these increased rates of chronic health diseases, and this impacts obviously the individual, the person suffering from this, but the families, as well as the health system having to manage all of this. And that's definitely a big issue in Australia, and no doubt Hong Kong as well, as having the funds to deal with so many people through the medical system that are relying on hospitals and doctors and medications to keep them well. Well, not really keep them well, keep them alive. We want to keep them well. So in relation to cognitive decline disorders, without intervention, the prevalence of Alzheimer's and dementia is predicted to increase almost threefold in the next 30 years. So I imagine that most of you listening would know someone who, a family member or a friend that's had Alzheimer's or dementia. It's already very common. And it's predicted to increase significantly. Here in Australia, the number one or the leading cause of death for women are actually dementia. For men, it's cardiovascular disease. For you in Hong Kong, it's not actually one of the top 1 or 2 leading leading causes of death. For you, your causes of death are different. There is cancer up there at the top, and based on the latest information that I saw, which I think was 2019, perhaps 2018, dementia was the 7th leading cause of death. However, if you do look at your statistics, you'll see that it's increasing up. The year before that it was 8. I think before that it was 10. So it is creeping up and becoming more of an issue for you in Hong Kong as well. The age of age-related cognitive decline is believed to be, or the age of onset is really believed to be at least 20 to 25 years before the symptoms even appear. So what that means is that someone doesn't just wake up one day and have Alzheimer's, or wake up one day and have dementia, or wake up and all of a sudden they don't know how to drive, they're having memory problems. This is something that happens over a long period of time, like with all chronic disease. So there really is a large window of opportunity for intervention. Right now, there is no treatment, and the only approved medications can just slow the progress and lessen the clinical signs. And if you are someone that does treat or provide medications for patients with Alzheimer's, they aren't necessarily for Alzheimer's. I know when my mum was sick, They thought that she had a seizure. She went on something called gabapentin. And to be honest, that was the day that we really lost her. She became a little bit like a zombie. There was, even though she had was having memory problems and some issues, there was still a little bit of my mum within her. She could still have a laugh. There were moments where she knew who I was. But as time went on, she went on more and more medications to deal with certain symptoms, not necessarily the Alzheimer's, but the gabapentin really was the day that her personality was gone. And soon after that, she couldn't walk, couldn't talk at all. And then we had 10 years of her really in a high care facility, not able to walk, not able to talk, not able to, having to wear adult diapers, being fed, things like that. So no way to live. And she was on a number of medications keeping her alive. And I really just don't think that is the way for anyone to live at all. So current research is not looking promising in finding a suitable treatment. And here what I'm talking about are pharmaceuticals. We don't have a pharmaceutical drug or a treatment for Alzheimer's and dementia at this point in time. And there aren't any drugs that are looking like they could treat that and reverse what's going on in the brain. Multiple international sources here in Australia, so Dementia Australia, as well as some in Europe and America, suggest there should be an increased focus on changing the modifiable risk factors to reduce incidence. And I'm going to explain what that means. So when it comes to these risk factors, some people are more inclined to develop Alzheimer's and dementia. There are non-modifiable risk factors, things we can't change, and that's age. So it's a fact that as we get older, we're more likely to develop these things. And genetics plays a big role as well, and we can't change our genes. However, there are many modifiable risk factors that we can change through diet, nutrient intake, and lifestyle that can reduce our risk for developing these diseases significantly. So when we look at the non-modifiable ones, the ones that we just can't change, we can't change our age. Unfortunately, I'd love to know how to do that. We can just focus on the healthy aging part. So age is an issue. Family history. If you have a family history of Alzheimer's or dementia, as I do, it's likely that you do have a genetic predisposition. And when it comes to the genetics, it's actually the ApoE. So ApoE, and it's the E4 allele, I'll explain what that means, is the particular genotype or what you inherit that is strongly associated with increased risk for Alzheimer's and dementia. So the modifiable risk factors, the things that we can change and we should be working on to reduce our risk of Alzheimer's and dementia, are hypertension. If someone has high blood pressure, that increases your risk for developing Alzheimer's and dementia. And I will admit that my mum had high blood pressure from a young age, despite being relatively lean and having a clean diet. She wasn't overweight at all. She did, I don't know, I've not done my mum's genes, but I know for me, genetically, I'm very much predisposed to high blood pressure. I've got genes linked with ACE and AGT and that renin-angiotensin system that regulates our blood pressure. Plus, she was a little stress head. My mum did stress a lot, and no doubt that would have impacted her blood pressure. But she was on medication from a young age and didn't know any different. That's what the doctor said. So she treated that through medication rather than through lifestyle. High cholesterol or hypercholesterolemia is also a risk factor. So, ensuring that your cholesterol levels are in a healthy range, particularly thinking about that, good HDL. Having diabetes, being obese, lesions in the brain and cardiovascular disease. These are all things that increase risk that actually can be modified through lifestyle intervention. So lifestyle-related risk factors are diets high in saturated fat, excessive alcohol consumption, smoking, cognitive inactivity. So you've probably heard, things like keeping the brain active, go and learn a language, do puzzles, do things that are going to keep your brain working, particularly after you've retired. Physical inactivity, low education, and social inactivity. So it's really important for people to have these social connections. And particularly after COVID, it's important that we are reaching out to loved ones and the elderly as much as possible, because isolation and social inactivity is something that increases risk for depression, which is also one of the risk factors for Alzheimer's and dementia as well. So let's talk about ApoE, which is the main gene that has the risk around Alzheimer's dementia. So this is the one that really seems to increase risk more than any other genes. Now, I have to say it's not the only gene that has been linked with Alzheimer's and dementia, but by far does seem to have the biggest impact. So what are apolipoproteins? So apolipoproteins are structural components of lipoproteins. So if you look over here on the right, we've got this kind of molecule here, and you can see that apolipoprotein embedded here. And it's really something that can sit on the cell surface, and it can act as an enzyme or a receptor. Things can bind to it, and it actually helps fats or lipids be absorbed and be transported through the blood. Because if you think about lipids and fats, they don't mix well in blood. You know, they don't dissolve, they're hard to transport. So by having these apolipoproteins, they kind of carry these lipids through the blood, help transport it to particular tissues and getting it into cells. So they bind to these hydrophobic lipids in the blood, helping solubilize them so they can be transported through our body. They transport cholesterol, triglycerides, phospholipids, as well as fat-soluble vitamins between the intestines, the liver, and the peripheral tissues. In addition, something that some people don't know about these apolipoproteins is not only are they transporting the fats around the body and fat-soluble vitamins, they're actually helping get rid of hydrophobic compounds, so fat-soluble compounds, things like heavy metals or other chemicals and toxins that could be sort of, you know, found within our fat cells. You know, we know that we store a lot of these things in our fat, so they can actually help get rid of those as well or transport them. So as you can see down the bottom here, the last point, transport toxic foreign hydrophobic compounds from areas of invasion and infection, so clearing them out of the body. There are many different types of lipoproteins containing different classes of proteins. Oh, I see something flashing here. Chat. We did say that was going to be interactive. I can open up. How do I open up the chat for you? I just clicked on chat. Is it going to? Oh, here we go. Oh, okay. So I think it's just died, just saying opening up the platform for the presentation for those who want to speak and ask questions. So I don't think there is a question there. I'm going to move this chat box over. Oh, I just lost it. But it's something flashed then. So if you do have questions throughout, just know I am happy to stop at any moment. As Denise said, I do like interactive things. You're not going to be interrupting me. So if I do see something pop up, I'm very happy to answer that in the moment. Or if I miss it because the screen's gone away, but I think I can click it if it pops up again, I will come back to all of your questions at the end, and I would love questions. That's the way that we all learn and can share information. So getting back to this, we know that there are many different apolipoproteins, and they are classified, as you can see here, ApoE, ApoB, ApoA1C, etc. And they all have slightly different functions. So they may be more specific at transporting, you know, certain fats. Some may be more, you know, transporting triglycerides. Other ones, your HDLs, other LDLs, things like that, chylomicrons, etc. Well, these are our chylomicrons, you know, these things that are transporting our fats. We know that altered function is associated with various disorders, including dyslipidemia, which is no surprise because this is important for transporting, absorbing, and metabolizing our fats. But they are also linked with risk for cardiovascular disease and particularly Alzheimer's dementia. And it's the ApoE that links specifically with Alzheimer's dementia because it's the one that gets the cholesterol and fats to the brain and helps get rid of and clear things from the brain, those fat-soluble toxins. So ApoEs are considered risk markers and important research targets, but their functions have not been fully elucidated. So even though I'm talking to you about the things that apolipoproteins do, we don't completely understand. And just know that there are millions and millions of dollars being invested into research by a number of pharmaceutical companies, as well as universities and government bodies to try to understand these more, particularly because we know that there is this really strong risk with the ApoE, with Alzheimer's and dementia. And if we can somehow modulate that, that could potentially be a therapeutic strategy around reducing risk for cardiovascular disease as well as Alzheimer's. So ApoE is the apolipoprotein that gets lipids and cholesterol to the brain and to our neurons. It's the brain ApoE that's also been shown to promote amyloid beta clearance, which we know is a problem and can build up in Alzheimer's and dementia. The clearance of heavy metals, so there have been suggestions that high mercury in the brain is linked with Alzheimer's and dementia as well, and impact on signaling between the neurons in the brain. There are two particular genetic variations. And if you're new to genetics, just know that we all have these slight variations, these slight changes in our genes. And this is how we identify those. So the RS number here, this is just sort of the ID number that's telling us what the variation is. And the C to T, our DNA is made up of 4 bases, A, T, C, and G. So we've just got a single base pair variation, which you can see results in an amino acid change. So we have these 2 genetic variations. It's just 2 base pair changes within the ApoE that seems to have a really big impact on the function of ApoE and risk for both cardiovascular disease and Alzheimer's. So I'd like to share this table with you and just give you a bit of an indication of that risk. So, and also of the frequencies, how common these genotypes are. So when we are looking at those 2 slight variations, the changes in that ApoE protein or the ApoE DNA sequence, we actually classify them and refer to them as either E2, so ApoE2, ApoE3, or ApoE4. And the reason why you see 2, 2, 2, 3, 3, 3, 3, 4, 4, 4 is because you inherit everything in duplicate. You get genes from mum and dad. So you're either a 2, 2, depending on what you've inherited. And if you are a 2, 2, that's actually associated with reduced risk of Alzheimer's disease. However, it's very rare. And I have to say, I do a lot of genetic testing. I've never seen a 2, 2. Know though that it's not necessarily all good news. I mean, it is great in the sense of reducing risk of Alzheimer's, but these people tend to have much higher triglycerides. And anyone that knows a bit about genetics, or you might have learned it at medical school, the E22 is actually associated with an inherited genetic familial hypertriglyceridemia, if I can get it out, but basically high triglycerides. And in some cases, some people do need to go on medication to manage their triglyceride levels. So it's not associated with the risk of Alzheimer's, but can impact on triglyceride levels. The 2, 3 is a little more common. I've seen a few of these, and this tends to reduce risk of Alzheimer's as well. The 3, 3 is the most common. Most of you listening today are likely to be the 3, 3. And that's associated with normal or average risk of Alzheimer's disease, and that is 5%. So most of us, that's sort of the average risk. About 5% will go on to develop. This can change, obviously, with age as you get older. The 3, 4, this is the one that I have. I have one of the 4s. The 4 is the risk allele. The 3, 4, we have about 20% of the population. That's associated with about a 20% risk of developing Alzheimer's dementia. And you can see the 4, 4, which again is rare. However, I have to say, I do see a few of these, but maybe these people are seeking me out because they know I work in the area. But I definitely see enough 4, 4s to feel like they're more common than 2%. The frequency does change slightly depending on certain countries, but we are quite similar to the US. And that is, increases risk for Alzheimer's dementia to, close to 70%. So a really big risk there. And I thought I would just add in a paper specifically for the Hong Kong population to show that, and there's not a lot of studies focused specifically on Hong Kong, but there was this one back in the late 90s showing that ApoE was associated with Alzheimer's amongst Hong Kong Chinese. But before I go on, I want to talk to you about what's known as the Nigerian oh, what's it called? I was going to say hypothesis. That's not it. But it's basically, there is this, I guess, conundrum in the sense that we say that the ApoE4 is strongly linked with Alzheimer's disease. And in Nigeria and parts of Africa, they have the highest frequency of this E4 allele. So the E4 is the one that we have seen, particularly amongst Westerners, Australians, Europeans, in the UK, Hong Kong, and in Asia. We've seen that the E4 links with increased risk for Alzheimer's and dementia, significantly increases risk. But in Nigeria, they have the lowest rate of Alzheimer's and they have the highest rate of E4. So for some reason in Nigeria, they don't seem to be having the same impact, or this doesn't seem to be increasing their risk of disease. So E4 in this particular population is not associated with cognitive decline. So why is that? Well, we know that ApoE is actually the principal cholesterol carrier in the brain. So it's about getting fats and cholesterol to the brain and then getting rid of these hydrophobic toxins and things like that. Nigerians actually have very low cholesterol from their low intake of animal fat, and they mainly have a diet of grains and vegetables. They're also extremely active. They have a completely different lifestyle. They have less hypertension. And if you remember the modifiable risk factors, things that increase risk for Alzheimer's dementia, aside from the genetics and the ApoE, was the hypertension and high cholesterol. So they are two of the big things that also increase risk for Alzheimer's dementia. So in Nigeria, they have low rates of cardiovascular disease, low rates of hypertension. So in this particular case, despite having this risk allele, it seems that their diet and their lifestyle has trumped their genes. And I really wanted to share that with you because we all have these genetic predispositions. However, our lifestyle plays such a big role, and we really can do something about reducing risk. And that's really why we're all, functional medicine practitioners, because we want to help people really address these root causes so that they can be truly well, despite their genetic makeup. So just to remind you what those modifiable risk factors for Alzheimer's disease are and what we need to be working on with our patients. So a Western diet and obesity increases risk. So for you in Hong Kong, you may not be really having that issue of a Western diet, though obesity could still be a problem. People carrying, even if they're not hugely obese, but carrying a lot of weight around the middle, that adipose tissue around the middle. But it's really just this sugar, the processed foods. That's what we're talking about with the Western diet. Elevated midlife total cholesterol. So in midlife, if someone has high cholesterol, that is a red flag or an indicator for both cardiovascular disease and Alzheimer's, and something that you can change and bring down. Again, midlife systolic blood pressure, because remember, they have hypothesized that really Alzheimer's dementia starts that 20 to 25 years before. So if you're in your 30s and 40s and you're having high blood pressure, high cholesterol, you really want to be modifying that so that it doesn't end up being or turning into a chronic disease. Midlife smoking is also associated with increased risk for Alzheimer's, particularly with those that have the ApoE4 allele. And if you don't do genetic testing, that's fine. You can still get a bit of an indication if you have a strong family history or your patient has a very strong family history of Alzheimer's and dementia. It's likely, of course, we can't say for sure unless you do genetic testing, though Denise was telling me it is becoming a little more common over there in Hong Kong. But if there is a strong family history, you can suspect that the E4 allele has been inherited. So the risk from treatable factors, including high cholesterol and blood pressure, appears to be greater for the E4 allele. So again, those people like myself that have the E4 allele, if I can manage my blood pressure, manage my cholesterol, I actually can bring my risk down to that normal level. So you can change your risk through lifestyle. And now let's talk about some specific therapeutic interventions. So when we talk about diet, majority of the evidence really lies with the Mediterranean diet, reducing risk for Alzheimer's and dementia. So it's no surprise that the Mediterranean diet pops up, and that is because there have just been so many studies for a long time. Since the 90s, they've really been looking at the Mediterranean diet. And this really started because there were groups of people over in Europe that were living longer. So we're talking about healthy aging and longevity. And they started investigating the Mediterranean diet. So the Mediterranean diet is predominantly plant-based. It's not vegetarian or vegan, but it's predominantly plant-based. Lots of fresh fruit and vegetables. They do have some whole grains, a little bit of red wine, not too much. We may not want to be suggesting that. But also they don't have a lot of saturated fat. Remember, saturated fat has come up multiple times in being a risk factor for Alzheimer's and dementia and cardiovascular disease. So the fats in the Mediterranean diet are predominantly olive oil, and nuts and seeds and things like that. So not a high saturated fat and predominantly plant-based. They do have a lot more seafood and oily fish and chicken every now and again, and red meat on average. Obviously everyone's different depending on where you read about the Mediterranean diet, but red meat's really only about once a month, so not a high meat diet. Different to the Mediterranean diet, we now are really seeing new evidence around a ketogenic diet, being able to restore metabolic function, including helping with cholesterol and lipids, and really supporting insulin sensitivity. I think we all know that going keto really does help with insulin sensitivity. And a ketogenic diet may also help reduce cognitive decline and help reverse early stage Alzheimer's. So you would know that both of these diets are quite different. A ketogenic diet is a lot heavier on meat, a lot heavier on fat, unlike the Mediterranean diet, which is, more so plant-based. But what I would say to you, and probably no surprise as functional medicine practitioners, is that there are similarities in this diet in that they are getting rid of sugar. They're getting rid of processed foods. And if we can get our patients to start to eat more of a whole food diet, and perhaps think more about fats from olive oil, nuts, seeds, avocados, perhaps a little less saturated fat, I think that is the benefit. And when we are talking about fat, there are lots of studies. I've just given a couple of references here, but there are a lot more showing that regular fish intake or even taking fish oil, I think it's the second study there is actually a study with fish oil, is shown to benefit cognitive performance and blood lipids in ApoE4 carriers. So it can help with reducing early cognitive decline, and definitely, as we know, helps with those lipid profiles. And when you are talking to your patients about diet, remember that herbs and spices are a great addition to meals, and you can chat to Denise Tan. So she obviously does food demos. I'm not sure if she's doing them now with COVID, but she does a lot of cooking demos and talks about meals and things like that at their beautiful place in Hong Kong. So really what we just want to be teaching our patients is to think about real food. I call it a low stress diet, getting rid of the sugar, getting rid of the processed stuff, the things that's going to be stressing their body. The other thing to think about is fiber. So high fiber diets and plant-based foods can lower total cholesterol as well as LDL cholesterol. And that's really the cholesterol that we want to be more concerned about. It's not really cholesterol as a whole. We know that the HDL is quite good. And the LDL, it's really in the presence of oxidative stress. It's the oxidized LDL, or those small, really small particles that do the damage. Cholesterol itself is actually really important for cell membranes, for the brain, for making hormones, making vitamin D, etc. So cholesterol is not necessarily the baddie, but there is very strong and robust and reliable evidence linking that higher LDL and cholesterol with Alzheimer's dementia. Just note that most of these people too, remember, are they're likely to be overweight and not eating a healthy diet. There is a difference, I think, between, having high cholesterol on a healthy diet and high cholesterol on a diet that is not so healthy. And that generally comes down to that HDL-LDL ratio. You really want to make sure they've got plenty of HDL. And that you obviously can manipulate through getting more of those omega-3s and good fats in. So vegetarian and vegan diets have been shown to reduce cholesterol levels and the risk of blocked arteries. And there are specific foods that have been shown to lower cholesterol, including those fiber-rich foods, green leafy vegetables, some fruits, Oatmeal, I'm sure you'll know that oats are really good at binding up that cholesterol and helping us get it out of the body. Avocado, some of the nuts, red wine in moderation, though, if your patient is coming to you with cognitive decline issues, particularly early stage, because that's where we really can intervene. I have to say that I have had some really good success with those with early stage cognitive decline. And generally, we don't want to be advising wine. You know, it can cause a bit of oxidative stress, inflammation, put pressure on the liver, etc. Garlic is good. And for some people, you may want to actually introduce some products or supplements to help bring in some fiber. So I really like the Pure Lean fiber, and Pure's also got the arabinogalactin. That's a prebiotic, so really good for gut health. Actually, well, I don't know if you can even see that. I've got my morning smoothie here, which has got a little bit of prebiotics and fiber and all sorts of things in it. So let's get on to the nutrient intervention. So in addition to talking about, you know, the omega-3s and the oily fish and the dietary factors that play a role, we know that low vitamin B12 has been linked with Alzheimer's, dementia, and cognitive decline, and high homocysteine, particularly in those with the E4 allele. And we know that as people age, their vitamin B12 levels tends to drop. And that's because digestive function can start to not work as well. And B12 is, you know, a very large molecule. It requires, like iron, a certain pH, but also intrinsic factor. And it's just a bit more difficult to absorb and to utilize. So as people age, they tend to have lower B12. So if you are working with someone who you are concerned about cognitive decline, definitely think about a B complex. If you can, measure homocysteine to get an idea if it's, you know, high or low, and give you an idea if that's an issue. But when it comes to the B complexes, Pure Encapsulations has so many to choose from. There's the B complex plus. I know that Denise was telling me the B6 complex is quite popular over in Hong Kong. That's obviously got a bit more B6, which has also been shown to help with supporting neurotransmitters and brain function as well. And what you do have access to, which we don't have access to here in Australia, is the Ultra B with the PQQ. So I'll be honest, PQQ is something that's relatively new to me. I learned about it from one of my patients who was interested in fertility, who came to me, and I started reading about this in relation to, so I guess a little bit like CoQ10, but different, but definitely helping with mitochondria. And I think from a brain health perspective, there are some studies with PQQ, and I think this particular product could be really beneficial, and I can't wait until we can get it here in Australia. So when it comes to supporting, you know, or reducing inflammation, which we know is another driver of chronic conditions, and inflammation in the brain is linked with Alzheimer's and dementia. Plus, there are a number of studies showing that omega-3s can be beneficial for reducing cognitive decline. Again, Pure has multiple omegas. I personally use the EPA DHA with lemon, particularly because my children like that one. They just chew on it. And just have the oil. However, the one omega does have the higher levels of EPA DHA, and this kind of matches, this one matches a little more with the research studies. I am going to show you one with dosages that seem to support cognitive function. Curcumin has also been shown to reduce risk of cognitive decline and support inflammation. And for those of you who've been to my previous lectures, you'll know that I've done talks around autoimmune health. We've talked a lot about curcumin, similar to omega-3s in that it really is a very powerful anti-inflammatory, working through those sort of similar pathways. And there is that curcumasorb. And there's a curcumasorb, a normal curcumasorb, that's the one that I'm familiar with, but there's also a curcumasorb mind. So this one particularly, it has the curcumin that is in a formulation that helps absorption. So one thing with curcumin is it is a little difficult to absorb. So you want a formulation that's been shown to actually absorb and get into the body. But then this particular formulation has got additional things, some antioxidants, again, really good for the brain. The other thing with curcumin too, when I mentioned with the diet, you know, adding herbs and spices, one thing I often do when my organic veggie box arrives, which is today, it's a Friday, is I often roast a lot of veggies just so that I can quickly, get those if I'm making salads. And I actually like to put turmeric, which the curcumin comes from, over my veggies and things like that. And then add a little bit of olive oil and some other things, because having that bit of fat helps, a bit of pepper, all those things helping with absorption. Vitamin D is also really important. So speak to your patient about, are they seeing the sun? Perhaps you can do some vitamin D levels, see if they need some vitamin D. And there is research around antioxidants and mitochondrial support, helping those with cognitive decline, particularly resveratrol and the CoQ10. And again, when we're thinking about the pure products, they have a CoQ10 and PQQ product together. So really good for the mitochondria. So in addition to these key nutrients, thinking about the Bs, thinking about supporting, inflammation, the omegas, curcumin, and possibly some antioxidants and mitochondrial support, you also need to, from a functional medicine approach, think about any other nutrient deficiencies they may have. Are they low in zinc? Are they low in magnesium? We need to obviously top these people up with all their nutrients and give them all the support we can so that they can start healing and getting better. So this is just one study. There's so many when it comes to the omegas. When it comes to cognitive decline, I would say it's probably the B vitamins and the omega-3s have the most research. And I'm just sharing this study with you because it does talk a little bit about dosages and suggesting that almost 500, but 480 milligrams of DHA and 720 of the EPA is what actually helped with cognitive performance. And that is similar to that one omega that we talked about. The DHA EPA, the one that I use, it doesn't have such high amounts, particularly of the EPA. I think the one that I use has got 200 DHA and 300 of the EPA, which you could obviously, have multiple capsules. People do, but the one has got higher amounts. The other thing I really want to emphasize to all of you is exercise. And I have to say that you are pretty good in Hong Kong. I know when I was staying in Hong Kong, the lovely hotel that Denise put me in, I could look out and there was, tennis courts and soccer and pools. Denise, you won't have to tell them where I was, or perhaps some of you may know when I describe that, but I could just see all these sporting things. And I remember going for a walk through the park and seeing people doing, elderly people doing some exercises in the park, which is great. I don't think we see a lot of that in our cities. We have an active lifestyle in Australia, but from what I saw, you seem to be pretty active in Hong Kong. We know that midlife leisure time activity at least 2 times a week is associated with reduced risk of cognitive decline, particularly for those ApoE4 people. So even if you've got this gene, like I do, and I've got a strong family history, it doesn't mean that you are definitely going to get the disease. If you can do this, look at your diet, make sure you're not deficient in nutrients, and, do some exercise, which not only helps support ApoE, I haven't talked about it today, but there's another gene called BDNF, brain-derived neurotrophic factor. It helps support the neurons and keeps them firing and working. Exercise boosts BDNF, makes you feel good, helps with memory, helps with learning. So many good studies around exercise. So daily exercise also improves cognitive function in patients with cognitive impairment and reduces brain amyloid. So, great research here. And, not a lot of people talk about this, how important exercise can be for brain function in those that are experiencing cognitive decline. And ApoE4 carriers have actually been shown to experience greater positive benefits of exercise. They actually enjoy it. I know I love exercise as well. And then from a lifestyle perspective, I don't need to spend too much time here. Sleep, we all know, is absolutely essential for health. As we age, we tend to sleep less, but getting into that deep sleep, that REM sleep, so our bodies can heal, flush out the toxins from the brain. We need to be reducing exposures to chemicals and toxins. There are studies suggesting that there are numerous things that can cause chronic disease and Alzheimer's and dementia, but exposures to molds, heavy metals, particularly chemicals and toxins, are thought to be one of the triggers. Weight loss for those that are overweight, reducing alcohol, quitting smoking, working on stress management, particularly when you're all in Hong Kong and working such long hours. And I do know that you really do push yourself over there. Mindfulness and relaxation, which really ties into that reduced stress, making sure you are connected, as I said at the beginning of the talk, Social isolation, social inactivity is linked with cognitive decline, mental health disorders, and neurological disorders like Alzheimer's and dementia. And exercise, exercise, exercise. Exercise with a friend helps you with stress, helps with social connections. You might be easy to stop smoking, helps with weight loss. The exercise and the diet and getting in some key supplements can make such a big difference. So we're near the end, and I just wanted to share this particular slide with you. If you haven't heard of Dale Bredesen, he's someone who's doing some amazing work. I saw him talk a few years ago in New York and almost cried. My mum was still alive at the time. He is really focused on Alzheimer's research, and I kind of ran up to him in the end, explained about my mum, and actually ended up connecting him with someone in Australia, and he came out and did some talks with us, which is great. But he has this Alzheimer's clinic. He was one of the first. There are more. He's not the only person with an Alzheimer's clinic right now. There are more in the US, and there are huge studies going on throughout Europe looking at similar things to Dale Bredesen. And basically, he's putting together protocols with all the things I just talked to you about. Diet. So he actually suggests a sort of like a modified ketogenic diet. So not so much the Mediterranean, but keto style, definitely getting rid of, all the sugar and things like that. So keto style, key supplements, as I mentioned, the Bs, the anti-inflammatory, antioxidant nutrients. Excuse me, I could feel that coming. And, exercise. So he has this real sort of lifestyle protocol. And if you actually go to his website, you can find he's got publications. And when I saw him speak quite a few years ago, I was really moved because he had videos of some of his patients. And at that time, I'd never worked with anyone with Alzheimer's or cognitive decline. I didn't even know you could reverse cognitive decline. I thought once you were diagnosed with Alzheimer's, that was it. But he was the first person that opened my eyes, and I saw people that were describing things like what my mum went through, forgetting how to drive, just getting lost, all of these things. They're having to leave work, but now they were back to themselves. They were getting back to work. They were able to drive again. They weren't getting lost. Their memory problems had gone away. So it is possible, particularly in the early stages, to reverse cognitive decline. It becomes much more difficult when someone is really sort of enduring those advanced stages. I have had one patient with advanced Alzheimer's and definitely didn't cure her, but made a significant difference to her life in the fact that she started playing with her grandchildren again. She had asked for knitting needles, so she hadn't actually knitted in years. And after some dietary changes, her daughter was amazing and trying to really help her. So her daughter had come in, was changing her diet. We'd put her on supplements. She had high homocysteine, high cholesterol, all these kind of things that we're working with. And as time went on, she just began to engage a little more with the family. She definitely still had Alzheimer's, had major memory issues, needed help around the house, but was just wanting to interact. And actually at one of her dinners asked for wine. They just gave her grape juice. But that was just a really beautiful moment. And we can do a lot for these people. And I don't think, I definitely didn't know it prior to a few years ago. So in summary, age-related cognitive decline disorders represent an increasing worldwide healthcare epidemic. We have an aging population. This is a problem that is not going away. We do not have any medications, and we know that we can do something. However, early intervention is key. Now, I understand that most people in their 30s and 40s may not be ready to make these changes. I obviously have a personal history. I've had an autoimmune disease. I work in the area, so I'm actively trying to work on my health. But even if people aren't working on these things 20 years prior, if you do notice or your patient comes to you and they start talking about some memory problems, intervening as early as possible is your best chance for turning this around. So as I mentioned, there are no treatments. Research has provided evidence for specific modifiable risk factors and protective factors. Focus on those with your client, with your patient, working on that high blood pressure, getting that cholesterol down, working on their weight, getting their brain moving, getting their body moving, all the diet, things like that. So as I said, these risk factors and protective factors include the vascular, lifestyle, dietary, nutrient, and psychological risk factors. Psychological, here I'm talking about that social interaction, the importance of mental health, that may act independently as triggers for Alzheimer's dementia, as well as interacting with each other. And as functional medicine practitioners, we all know that it's really not one of these. It's all of these things coming together that generally result in the development of a serious disease. And we want to be working on all these factors to get people truly well. So preventative treatments have been shown to be the most effective. As I said, I've shown you one example, Dale Bredesen, who's really a leader in this field, but there are other people opening up clinics. It's definitely something that I want to do in the future here in Australia. And when treatment, these therapies, the diet, the supplements, getting them moving, letting them know that there is hope. I know for my mum, when she was diagnosed, and any of you who have been with someone who's been diagnosed, generally they're just told to get their affairs in order. There's nothing they can do. But that is not actually true. If people are willing to do the work, they can actually reverse some of these symptoms. But it's important to do this as early as possible in order to prevent or postpone the onset of age-related cognitive decline and support brain health. So I thank you all. I realize I didn't open that little chat box, but I don't think I saw anything flash up. Shall I stop the share here?